Good morning on this beautiful July 8th, 2020. I hope everybody is doing well. I wanted to discuss the current situation in the United States, selecting various states. I'm selecting states that have been hotspots as well as those, that are current hotspots. And I'm particularly focusing, as you can see here by my highlights, in Arizona, Florida, and Texas. Now, I use the Johns Hopkins website to gather data because that pulls data from so many different sources. If you look at, I think probably what's the most important column here is mortality rate. So mortality rate is the number of deaths divided by the population total, and I have the population for each state written down, multiplied by 100,000. So you'd see this is how many deaths you'd get per 100,000. We use 100,000 because it gives us a good context. Some people would like to look at prevalence. Prevalence is a similar type number. It's the number of cases, active cases per 100,000. Now, the only issue I have with this and why I'm not so focused on prevalence is that certain states, I'm not getting the number who've recovered, so we're getting falsely high levels in those states because we have to have the number recovered in order to, we have to subtract them in order to get the number of the actual prevalence per 100,000. But if you want to look at those, that's fine too. I also graphed several of the states. I had this figure before, but it was way too active. There were too many states. There's too many states in there, so I cut it down to states that are of most interest to me right now, including Arizona, Florida, Texas, Massachusetts, New Jersey, New York, Illinois, Pennsylvania, and in the United States overall. So this is the mortality rate per 100,000. So you can see that New Jersey and New York still have New Jersey, New York, and Connecticut have very, very high mortality rates, as well as Massachusetts. And then we go down from there with Louisiana. At the lowest ones we can see are in the states that I'm most interested in, which are Texas, Florida, and Arizona. Obviously, I'm interested in these because they've had a lot of disregard for mask wearing, and that's something we have to be careful of. Yet, the mortality rates are still highest in states where we have the highest density of population, and then Connecticut because it's so close to New York and New Jersey, as well as Massachusetts. So this is just interesting, and it's a way to keep perspective. These, of course, are data based on today. They're the latest data on the 8th of July, 2020. Just a couple of other interesting points that I want you to note. I was looking at some of the information. I heard recently somebody say to me that COVID-19 is a vascular disease. It cannot any longer be considered a respiratory disease. So I didn't say anything in the moment because I never want to say anything if I'm not informed. I went through the research and looked at the data, and I can see where there was an article, I think it was in Scientific American, that hypothesized, and this is the key, that's a hypothesis. A hypothesis isn't reality. So what we're seeing a lot now is that people who are working on the front lines are making these hypotheses because they're seeing these cases and they're saying, this is interesting. But that a hypothesis isn't reality. It's not a law, essentially. To move from hypothesis, you have to do studies. To do studies, you have to collect data. You have to do, and in this case, we do what are called case control studies, because we can look at those who have had the disease and passed away, and then we can go back and look at risk factors or other precipitating factors. But at this point, there is no reason to say it is not a respiratory disease. Now, that said, the research that I read through shows that individuals who have cardiovascular diseases or pre-existing conditions, including high blood pressure, hypertension, diabetes, obesity, these individuals do suffer worse, and there are very bad cardiac anomalies that occur afterwards, and in many cases those result in death. Or in some cases, I should say, not in many, always in many, but in some cases it results in death. But to jump from this being a a respiratory disease to a vascular disease is very premature. In addition to that, I was looking at, because I work at a university and we're interested in reopening and we're trying to protect our students, I've also looked at the idea of screening. I found some interesting information in what is done in a hospital in China, and what triggered this for me was having to visit a healthcare provider yesterday for something unrelated to COVID. But the screening process for the coronavirus and COVID-19 is very thorough, and you're allowed in if you pass this test, and if not, you have to go to an alternative location that is prepared to receive individuals who are infected with coronavirus or COVID-19. So I read through this process, and it seems like a very good way of screening individuals, because the problem with testing is that we can't test everybody. And let's say you're tested and you walk right out of the testing center and encounter somebody with the coronavirus, you can get infected. So the test really doesn't do much. By the time you get the results, you could be already infected. So we need screening. We need a two-pronged process, and this is what was done in this hospital. You screen first using it was actually an app for a text message, and then completing this app, and then you show that you've completed this process by some kind of a scan of your cell phone or whatever on some barcode or something. And if you are positive based on that, you go on and get testing for the coronavirus. This is a sequential testing process, which is actually really, really good. I love it. The other interesting paper that I read was how the olfactory and taste anomalies that occur with coronavirus, it's been reported often that there's changes in abilities to taste, to recognize taste or smells when somebody's infected. This is only one study that reported, but this has been reported very often. But in this one study, the specificity of this was about 98%. What does that mean? Okay, so specificity is the probability of testing negative given you are disease negative. Had a 98% specificity. That's really, really good. So there's a 98% chance of correctly identifying somebody who's negative. Versus the sensitivity was only about 26%. So you had a 26% chance of correctly identifying somebody who has coronavirus using a questionnaire about one's loss of taste and smell. But we're more interested in terms of allowing people into locations about specificity over sensitivity, because we don't want to falsely proclaim somebody is disease positive when they're not and exclude them from education. Anyway, those are just some interesting things, and I think you should look more into those. And as we prepare to open, we have to find ways to open up. If we all close, then everybody's going to lose jobs, and that's not going to be sustainable either, because we're opening ourselves up for so many other diseases and health disparities and other issues. At any rate, be safe. Thank you and have a good day.